Well, hello, everybody, again. It is my great pleasure to be hosting actually a setup or a series of webinars that we're doing cross ERNs, and this is something that is really all about. So ERNs should be, mixing the knowledge and experience, and of course the speakers. So now we are doing a series on genetics and gene therapy. So it is my pleasure to announce Professor Dimitri Kullmann today. He obtained his BA and DPhil degrees from Oxford University and studied medicine in Oxford and London. After his postdoctoral work in San Francisco, he qualified as a National Hospital Queen Square, where he continues to see patients. His laboratory studies fundamental aspects of synaptic transmission and plasticity in the mammalian brain mechanisms and neurological channelopathies. He is also attempting to bring gene therapies to drug-resistant focal epilepsy to the clinic. He's a fellow of the Royal Society and of the Medical Sciences and was the editor of Brain between 2014 and 2020. He's currently a professor of neurology at the UCL Queen Square Institute of Neurology. It is my pleasure to have you start this webinar series, and let's see how much we learned today.
Well, thank you very much. So let me just put this full screen and get my mouse, laser pointer. Right, well, thank you very much for this invitation to talk about gene therapy for epilepsy. And I have to say right from the outset that I'm not going to be talking about rare neurological channelopathies or monogenic disorders. I'm going to be talking about common forms of epilepsy. And the other thing I'm to point out right at the beginning is I'm going to be talking about preclinical work. So here is a disclosure. So I hold equity in and act as an advisor to Epilepsy GTX Limited. So this is a company that we founded to try to bring some of these technologies to the clinic. So here's a summary of what I'm going to talk about. So focal refractory epilepsy, which we have modeled in rodents, responds to a number of different gene therapy strategies. And so these can be divided into constitutive, controllable, and closed loop. And I'll explain that as I went along. And some of these are being de-risked in preparation for a clinical trial. So as I said, I'm not going to talk about monogenic epilepsies, and I'm also not going to talk about RNA therapy and cell therapy. Some of those are actually also being advanced to clinical trials, and one is actually already in a clinical trial, which I'm not, for the interest of time, I'm not going to talk about. So, focal refractory epilepsy, I'm sure I don't need to remind this audience that epilepsy overall is an extremely common disorder. It affects approximately 1% of the population, and there are numerous etiologies and numerous syndromes. As you know, epilepsy can be divided up into lots of different ways, especially in terms of focal, i.e. partial onset, versus primary generalized, although focal epilepsy can also give rise to seizures that undergo secondary generalization. And focal epilepsy can arise from numerous different causes: birth injuries, tumors, strokes, malformations of cortical development, cryptogenic causes, and in many cases you don't actually know the cause of the focal epilepsy. And focal epilepsy is especially likely to result in pharmacoresistant or refractory epilepsy. So about 30% of people with epilepsy overall continue to have seizures despite optimal medication. And as you can imagine, the main reason why pharmacotherapy is limited is because it treats the entire brain and typically does not treat specifically those neurons that participate in seizures. So the side effects caused by effects on neuronal excitability, synaptic transmission, and also non-neuronal effects are limiting the dosage that you can administer. So that's why we have to look for alternative treatments. Surgery in focal epilepsy is effective, but as you can imagine, this is only appropriate in a small proportion of people because of risk of neurological deficit, and of course it's irreversible. Recently, there's been a lot of interest in laser interstitial thermal therapy, which is, it destroys a smaller volume of tissue, but it's still irreversible and is still limited by, especially in the case of temporal lobe epilepsy, risks of visual field deficit and some cognitive side effects. And then the other treatments, such as neuromodulation and ketogenic diet, are really palliative. It's unusual that you can actually achieve seizure freedom, and of course the mechanistic basis is poorly understood. So that's why we think that gene therapy has an extremely important role to play. And of course, gene therapy, by which I mean using a viral vector to transfer some genetic information into neurons, either DNA or RNA. Of course, it's only one of the different advanced therapies. There are also RNA therapies using antisense oligonucleotides and cell therapy, so transplanting cells. I think gene therapy probably has the most promising future of the advanced therapies. So gene therapy, of course, it consists of a number of choices immediately. Choice of vector, and the two main vectors that people have used are adeno-associated virus. So this is a small particle about 25 nanometers across. AAV is not associated with any human diseases. It's a DNA virus. And lentivirus is the other one that has been tried in a number of gene therapies. We've done some work with lentivirus, but it doesn't spread very far in the brain. And this is an RNA virus derived from HIV. So most efforts to do gene therapy in the brain have used AAV. And this is different. So what I'm going to talk about is using gene therapy to adjust excitation or inhibition. So in a way, working in a similar way as many of the anti-seizure medications, as opposed to trying to correct an underlying molecular lesion. And the reason for that is that monogenic epilepsy is very uncommon, and especially in the case of focal epilepsy. And monogenic epilepsy, of course, you would need to have some sort of tissue diagnosis in many cases. For instance, there are some somatic mutations, and a tissue diagnosis is not realistic in the majority of cases because it would require an invasive procedure. So instead of thinking about correcting an underlying molecular lesion, which is difficult to identify, most of our efforts have gone towards trying to adjust excitation or inhibition. And the advantage of gene therapy is that you can exploit the regional and cell type specificity of viral vectors and promoters. So promoters are what drives the expression of the transgene, and these can be non-specific, or they can be neuron-specific, or they can be even more specific in terms of biasing expression towards one cell type or another. For instance, we've done a lot of work with a promoter called CAM kinase, which biases expression towards excitatory neurons in the cortex. So this cartoon in the bottom right-hand corner shows a few of the molecular, a few of the transgene products, a few of the proteins that are encoded by some of the transgenes that we've been using. And I'll describe these in a bit more detail as we go along. Okay, so now when we think about developing a gene therapy for epilepsy, of course, we have to validate this in a preclinical model. And so in common with a number of other laboratories around the world, we've invested very heavily in rodent models of pharmacoresistant epilepsy. And there are a number of different models out there. But of course, we're not just concerned with seizures, we're also concerned with cognitive and behavioral comorbidities and off-target effects. We don't want to suppress seizures at the cost of causing some abnormalities of memory function, for instance. And that's why a lot of our efforts are directed towards monitoring seizures, but also monitoring behavior. So we use electrocorticogram or EEG, if you like, monitoring. We've developed our own wireless transmitters, and we validate the ability to identify seizures using video recording and using machine learning. So we use a computer-based analysis of the EEG or the ECOG to identify seizures, such as the one at the bottom here. So you can see the spectrogram and the electrocorticogram. So we try to use machine learning to identify this pattern to detect all the seizures, and we record continuously for many days and try to capture all of the seizures. And then we do behavioral studies, such as, well, I'll talk about some of those behavioral tests as we go along. Right, so when we think about what sort of tools we can use to adjust the excitation-inhibition balance, of course, this is a very simple view of how excitation and how inhibition work in the brain. So excitation, we think about sodium channels, which underlie the upstroke of the action potential, glutamate receptors, which are the main excitatory neurotransmitters. And then we think about inhibition as being at the cellular level, depending very heavily on potassium channels, which set the resting membrane potential and also repolarize the action potential, as well as GABA receptors, which are chloride channels. And these are the targets of many of the drugs that we already use in the clinic, such as the sodium channel blocking drugs, phenytoin, carbamazepine, lamotrigine. Glutamate receptors, or AMPA receptors, which is one of the subtypes of glutamate receptors, are the target of perampanel. Retigabine was in the clinic for treatment of epilepsy, although it was pulled, although there are some other drugs in development in clinical trials which target one of the many subtypes of potassium channels. And then, of course, there are lots of benzodiazepines and barbiturates which work on GABA receptors, and vigabatrin and tiagabine act indirectly on GABA receptors as well. So you can see that this actually encompasses a lot of the drugs that we use. Not on this slide, of course, are such drugs as sodium valproate and levetiracetam, which act through incompletely understood mechanisms or other targets. But still, this gives us a sort of a palette of molecular targets that we could exploit in gene therapy. So of these, historically, the first one that we worked with is a potassium channel, Kv1.1, and this was a serendipitous discovery. So quite a long time ago, my laboratory was looking at the consequences of some dominant negative mutations of KCNA1, which is the gene that encodes Kv1.1, and these mutations cause episodic ataxia type 1. And this is a cerebellar ataxia, where patients have these brief attacks of cerebellar incoordination. They also have interictal neuromyotonia. Some of these patients have seizures. And so my laboratory was working on Kv1.1, and then we made a serendipitous discovery that if we overexpress the wild type KCNA1 gene in neurons, we could reduce their excitability and reduce neurotransmitter release. And since then, together with numerous colleagues, some of whom are listed here with their photographs, we've validated gene therapy for epilepsy using this transgene in several different models. And I'll just summarize a few of the models and a few of the observations that we made in the next few slides. So this is a randomized blinded trial of potassium channel gene therapy using the KCNA1 gene in rats. So we try to model as closely as possible a clinical trial, randomizing to either treat with the potassium channel gene therapy or a control, which is just expressing a fluorescent reporter protein, the GFP, the green fluorescent protein gene. And we do it in a randomized intention to treat blinded way. And this just shows the time course. So we induce epilepsy. In this case, it was a focal neocortical epilepsy model. Over the next week or 10 days, we start seeing seizures. At this time point, we inject the lentivector. So this was using a lentivirus back in this particular study. And then we continue recording the seizures for the next 4 weeks. So this is an animal that received the potassium channel. We call it EKC. It's an engineered version of the potassium channel. And we do the same thing. And sometimes when we toss the coin, we give the placebo, which is the green fluorescent protein lentivector. And sometimes we give the active virus. And then we do this in a large number of animals. And then we crack the code. And then you can see that there's a highly significant difference in the frequency of seizures in this model. So here what we're doing is plotting the cumulative seizures normalized to the baseline. So they're normalized to the first week. So that's 1. So in both cases, the two populations of animals track each other, and then they deviate very rapidly as soon as we've done the gene therapy. So this is an example of the sort of approach that we've used. And so just to summarize some of the other studies that we've published, we first reported this in a model of neocortical epilepsy using a non-specific promoter called CMV from the cytomegalovirus. It's a very strong promoter in a lentivector. We then moved this technology into an AAV for the reason I mentioned earlier on, that AAV spreads better in the brain. Lenti tends not to spread very well. And we moved over to a different promoter. This is a CAM kinase promoter, the calcium calmodulin dependent kinase type 2 alpha, but often some abbreviated as CAM kinase. We engineer the potassium channel to alter its inactivation properties. And we validated it again in a neocortical epilepsy model and then in a temporal lobe epilepsy model. Since then, we've also reported efficacy using a different strategy, which is to upregulate the endogenous potassium channel. So this is using CRISPR. So you've heard of CRISPR to cut the DNA. We're not cutting it. We're using a CRISPR that's been a version of CRISPR that can't cut the DNA, but recruits a transcriptional activator. We also revalidated it in a mouse model of temporal lobe epilepsy, and then in a model of focal cortical dysplasia. Now, I'll talk about this last study in a bit more detail, because I think it's very important to remember the different types of epilepsy that we encounter in the clinic and how important it is to verify that a treatment can actually be used in different types of epilepsy. There's no point in developing a treatment, a gene therapy, an invasive treatment that would only treat one particular subset of patients. You really want to demonstrate efficacy across numerous types of epilepsy. And that's why, of course, we're targeting excitation inhibition balance, because we think that there are common mechanisms that go across the different epilepsies. So this is a study, so just a bit of background, focal cortical dysplasia, for those of you who are not experts. So this is a malformation of cortical development. And in the last 15 years or so, it's become apparent that this is caused typically in many cases by somatic mutations. And these somatic mutations, which occur in embryo, so as opposed to germline mutations, these are somatic mutations which affect a specific part of the brain. They often affect the mTOR, the mammalian target of rapamycin, or mitochondrial target of rapamycin cascade. And they lead to hyperactivation of mTOR. And this is a very common cause of refractory epilepsy, learning disability, autism, and other features. And depending on how early the mutation occurs, you can have very large or very small areas of dysplasia. And in the abnormal area of the brain, you have enlarged neurons and a number of other histological features, which you can recapitulate. So this is a study that was undertaken by Amanda Almasalas-Barbernoch, together with Vincent Magloire, Gabriel Lignani, two of my colleagues, together with a number of other people whose names I don't have time to list, where we induced a model of FCD using in utero electroporation in mice. And so here we take the mouse embryo, we electroporate, so we inject the plasmid, which activates the mTOR cascade, and they electroporate by putting little electrical paddles across the embryos, the brain of the mouse, and then put the embryo back into the mother. And then when the mouse is born, we then screen the mouse using fluorescence through the skull, looking for a reporter protein to indicate whether we've successfully electroporated and induced a model of focal cortical dysplasia. These animals have deficits in working memory, in social cognition, and about 50% of them have seizures, and they also have the same histological hallmarks of FCD. So they have construct and face validity. So then we recruit them into our preclinical study. We record a baseline of seizures. We do some behavioral tests. We then do the gene therapy. Again, we toss a coin and either give the active virus, which is the CAM kinase. In this case, we use a slightly different acronym, CAMK2A, promoter driving the engineered potassium channel, EKC, or the control virus, which is CAM kinase driving the green fluorescent protein. We wait for the virus to incubate or for the transgene to be expressed. We then record some more seizures and then do behavioral studies. And here we're displaying the results of the preclinical study in a slightly different way, using these colored plots where each rectangle is 1 day in one mouse. So on the y-axis, you have the different mice. On the x-axis, you have the 2 weeks of baseline recording. Then you have a 2-week pause for the virus to express, and then a further 2 weeks of recording after the virus is expressed. Where we have a cross, we didn't get the data. And so on the left, you've got the CAM kinase driving the GFP control virus. And then on the right, you've got the CAM kinase driving the potassium channel. And you can immediately see that although with the GFP controls, some animals had an increase, some animals had a decrease, but no overall change in seizure frequency. With the EKC, the potassium channel, all of the animals had a decrease in seizure frequency. And you can summarize that again using this baseline normalized cumulative seizure count. And you can see this highly significant difference between the two groups. And importantly, we wanted to make sure that these animals were not any worse in the behavioral tests, and that indeed there was no worsening of cognitive or social behavioral performance. We weren't correcting those deficits which were present in the mice, and we think that's because we're not undoing the miswiring of the brain, which is contributing to some of those abnormalities, but we certainly don't worsen them. So we think this again further supports the efficacy of this approach, the safety of this approach in terms of off-target effects, and indeed we are trying to advance this approach to the clinic. So what would the clinical trial look like? Well, one advantage of gene therapy in the case of epilepsy, as opposed to, for instance, gene therapy for Parkinson's or various other CNS disorders, is that patients are already, some patients are already having surgery, and therefore we would piggyback on the surgery program for patients with pharmacoresistant focal epilepsy. So what typically happens when patients are being considered for surgery for pharmacoresistant epilepsy is they undergo in-depth assessment using EEG, MRI, various other imaging modalities. If there is no contraindication to surgery, the normal practice is identify the epileptogenic zone. If it is feasible to resect it, then the patient comes back and has surgery to remove that area, or lit to destroy it using thermal ablation. And a clinical trial would consist of offering recruitment to the clinical trial to such patients. They have the focal gene therapy into the area of the brain that could come out. If the seizures continue, then of course they can still have the surgical resection. We then have the tissue. There's an additional safety component in the sense that we've removed the part of the brain that has been treated. If the seizures go away, of course, the patients are spared having to undergo surgery. So this is a very, very superficial description of what the clinical trial would look like. And currently we are finishing a number of de-risking steps, GLP toxicity in a different species, biodistribution studies, the GMP manufacture. Of course, that's an extremely important step, manufacture of a batch of clinical grade gene therapy, and working towards a clinical trial authorization. Now, this is, of course, a very simple approach. This is what I call constitutive gene therapy. One concern, theoretically, is that it's not possible to undo the therapy. Once we've inserted the gene therapy into the brain, you cannot then adjust its strength or to switch it off. So is there a way of making gene therapy controllable? Well, in fact, there is. And so there's an enormous number of papers in basic neuroscience using a technology called chemogenetics. So the idea here is to insert a receptor which is inactive until you give a drug to activate the receptor. And so these receptors are sometimes known as DREADs. These are designer receptors exclusively activated by designer drugs. And the most commonly used ones are derived from muscarinic receptors. So for instance, the M4 human muscarinic receptor has been mutated to make it insensitive to acetylcholine, but sensitive to a number of exogenous drugs. And so the idea is to put this receptor into the brain, into the epileptogenic zone, using gene therapy, so using a viral vector, and then give a drug on demand, or to use a drug to adjust the activity of the receptor, titrate the dose of the drug in order to have more safety margin in terms of trading off any side effects against efficacy. This would be theoretically very important if, for instance, the pharmacoresistant epilepsy focus overlaps with eloquent cortex, such as language areas or primary motor cortex. And so a while back, Dennis Ketzel, who is in my lab, we reported the first study using chemogenetics in a model of epilepsy. Since then, it's been replicated in a large number of other laboratories. And more recently, we thought it would be important to identify a ligand which could be used in the clinic. And we found that olanzapine is such a ligand because a lot of the preclinical work has been done using drugs which are not approved for use in the clinic by the FDA or the EMA. So olanzapine is a drug which is used in psychosis, and we found that using a very small dose of olanzapine, we could activate this receptor and suppress seizures on demand. And this is something which we published in a couple of papers. Now, I'm not going to say any more about chemogenetics. Of course, you could argue, well, the patient is taking, will still need to take this drug, olanzapine or another ligand. So is there really such a big advantage over taking anti-seizure medication? Well, yes, there is, in the sense that this drug is only working on that area of the brain and those neurons that have been affected by the gene therapy. So in that sense, it is still a major step forward. But can we dispense with an exogenous switch? Can we try to use an endogenous switch to activate a chemogenetic approach? So this made us think about, can we try to harness more information from how seizures occur? So we need to study a bit more in more depth exactly how seizure mechanisms occur in different forms of epilepsy. And so we've exploited the ability to study using epifluorescence, so using optical methods, seizures in awake head-fixed mice. So these are animals which are not anesthetized. And of course, it's difficult to study epilepsy mechanisms in anesthetized animals because anesthetics are anti-seizure drugs effectively. So we have used awake head-fixed mouse preparations. We visualize the brain either through the skull or by making a cranial window, and then we induce seizures using chemoconvulsants, either picotoxin or pilocarpine, just in a small area, and then we see how seizures occur. And so this is a study that we published a while back using calcium imaging. So this was Federico Rossi, Rob Wax, Matteo Carandini. We collaborated in this study. So on the left here, you see exposed through a cranial window a mouse brain. This is the occipital cortex equivalent in a human. So this is the posterior part of the brain where you have the visual cortex. And we have a local field potential electrode to record the seizures. And at the same time, we image the calcium in the neurons using genetically encoded calcium indicators. So these are fluorescent molecules encoded in a virus which we express in the brain. And then what we see is in the fluorescence, we see that we can induce seizures, and sometimes these seizures self-terminate. There's a slow down quite a lot, so you can actually see what happens. And sometimes the seizures escape from local inhibition and then spread across the brain. And so this made us think, well, why do some of these perhaps they're not really seizures as such, these brief discharges, a little bit like interictal discharges which self-terminate, why do they differ from those that escape from local inhibitions? So why do these spikes self-terminate and seizures spread? So this, in fact, is a question that's been around in the epilepsy literature for quite a long time. You have interictal spikes or interictal discharges, which electrographically look very similar to the sentinel spikes, which then are followed by seizures. So recently we've become able to image not just calcium, which is looking at neuronal activity, but actually glutamate and GABA, which are the neurotransmitters which underlie all the synaptic transmission, or most of the synaptic transmission, which we think is explaining excitation and inhibition in the brain. So this is using these genetically encoded glutamate and GABA reporters. They're sometimes called sniffers, glutamate sniffer and GABA sniffer. And this was work that my colleagues Vincent Magloire and Yoshitaro Shimoda did a few years ago. And we recorded these interictal discharges as well as the sentinel spikes that led on to seizures. And what we found was that both GABA and glutamate go up very, very prominently with each of these discharges. So the top line here is the GABA fluorescence, and this is the electrocorticogram accompanying the GABA signal. And this is where we image the glutamate signal. Again, the electrocorticogram shows the interictal discharges, and the glutamate, this is looking at the extracellular glutamate going up quite dramatically. And here is just aligning and averaging a few of these responses. So both GABA and glutamate go up with each of these discharges. And In fact, this isn't entirely novel. I mean, people have been arguing that these intrathecal discharges are accompanied by a large glutamate surge and a large GABA surge, and it's a little bit like a fire blanket analogy. So when you have a chip pan fire in the kitchen, you can smother it, and that effectively is what GABA is doing. There's a massive release of GABA into the extracellular space that suppresses excitability. But what happens with a seizure is that this inhibitory surround fails and the whole kitchen goes up in flames. So that's our model. And indeed, that's what we think is happening when we look at the difference between an intraictal discharge and the sentinel spike that then leads onto a seizure. We can see that the GABA release is smaller, but the glutamate release is bigger. So we see this shift from balanced GABA and glutamate towards more glutamate and less GABA, and that's what then determines that the seizure is going to escape. So now, can we actually use the glutamate signal as an endogenous chemogenetic agonist? If you remember the chemogenetic approach, we put in a receptor which is inactive until we using a lock and key analogy of pharmacology, we then give the key exogenously with a ligand, olanzapine or another exogenous ligand. Can we actually use the glutamate signal, which is what goes up with these spikes and these seizures? Can we use glutamate as a chemogenetic agonist? So, of course, glutamate normally we think of as an excitatory neurotransmitter. It acts on excitatory receptors, whereas GABA is an inhibitory transmitter which acts on GABA receptors. So what we're suggesting is, can we actually use glutamate to activate an inhibitory receptor? Well, it turns out we can. And so this is an approach that Andreas Lieb, together with a number of other researchers in the group, took a few years ago. And there is a receptor for glutamate which is inhibitory, and it's called GluCl. However, it's not a mammalian receptor. It's present in C. elegans and other invertebrates. And in fact, this is the target of ivermectin. So if you have worms, or if your dog has worms, you take ivermectin to activate this receptor. Now, we're not going to use ivermectin as the ligand. We're going to use glutamate because that is the endogenous ligand of this receptor. However, it's relatively insensitive to glutamate. So the first thing we had to do is to shift the sensitivity right down to 10 micromolar, which we estimated was the extracellular concentration of glutamate that would occur during these intraictal discharges and at the onset of a seizure. So we mutated the receptor to make it more sensitive to glutamate. And then we put it into a viral vector and then did the randomized study. And you can see that, again, we had a highly potent anti-seizure effect in this model of neocortical epilepsy. And since then, we've repeated this in a model of temporal lobe epilepsy, which we haven't published yet. And again, it was well tolerated. And so this is something which we are quite excited by. Of course, it's not a mammalian receptor. We are working on making it a chimeric receptor, which minimizes the non-mammalian part in order to reduce the risks of immunogenicity. Now, another way of thinking about closed-loop gene therapy is thinking about, if you treat an area of the brain with a gene therapy, do you really want all the neurons in the treated area to express the transgene? Now, as I said, we bias expression towards certain cell types by using either a neuron-specific or a promoter that is specific for excitatory neurons. But even so, within the treated area, we might end up treating neurons that don't need to be treated. When you identify the seizure focus, there may be some neurons there which don't participate in the seizures. So let me try to get this argument across using a cartoon here. So here effectively is in the ground state, some neurons are firing more than others, but in an epileptic state, there's a subpopulation of neurons which are firing much more than other cells. And what you really want to do is just to treat those. You don't want to treat the other cells. So if you do have a constitutive gene therapy using a non-specific promoter that only targets that targets all the cells or that targets all the excitatory cells, you may actually make some of the excitatory cells hypoactive, and that could have some off-target effects. So what we really want to do is to use a closed-loop gene therapy that allows the transgene only to be expressed in those neurons that need to be treated. So how can we achieve this? Well, Gabriele Lignani, my colleague who recently has been awarded a number of international prizes, had this brilliant idea of placing the transgene under the control of an immediate early gene promoter. So these immediate early genes are genes which switch on in response to pathological activity. There's a number of these genes that have been studied quite extensively. The most famous one is CFOS. We're not taking the CFOS gene product, we just take the promoter for CFOS and put the potassium channel under the control of this CFOS promoter. So under basal conditions, or in a neuron which is not pathologically overactive, the CFOS will not be promoter will not be active, the potassium channel will not be overexpressed. But if these neurons do participate in seizures, we anticipate that the CFOS promoter will work, will drive the expression of potassium channels. And so Yi-Chen Chu and Nathaniel O'Neill and a large number of other people in our laboratories participated in this very extensive study that was published just over a year ago. But let me get across the proof of principle. So we anticipate that because the CFOS promoter doesn't switch on immediately, but takes about half an hour to switch on, if we induce a seizure in a naive animal, it will not protect that animal from having a seizure, because the seizure happens within seconds. So if we inject, for instance, pentylene tetrazole, which is a chemoconvulsant, we anticipate that this animal will have a seizure which is just as severe if it's been treated with the gene therapy than if it's been treated with a control gene therapy that doesn't express the transgene. However, 24 hours later, the CFOS promoter will be active, and so if we then come back with a second injection of pentylene tetrazole, we should be able to protect these animals. Now, this CFOS promoter, we know from a large amount of published data, it switches on over half an hour or so. It stays elevated for at least 24 hours, but then after a while, it then switches itself off. So if we then go back and give a third injection of PTZ 2 weeks later, we anticipate that the animals will no longer be protected against seizures. And that's precisely what we saw. So here is the severity. So this is the Racine score. So the higher number, it means the more severe seizures. So if we do the first injection of PTZ, the seizure severity in these animals was no different between the two groups, whether the CFOS promoter was driving the potassium channel or driving just the reporter protein. At 24 hours, the animals expressing the CFOS EKC potassium channel gene therapy were protected, and then 2 weeks later, they were no longer protected because it had been switched off. Now, PTZ is not a model of epilepsy. It's a model of evoked seizures. So, of course, we had to go back and do the model of the epilepsy model. So here's a chronic epilepsy, a temporal lobe epilepsy study. And again, displaying these animals in a different way. This is the raster plots, just as showed earlier on, where every animal, every vertical line is every seizure. We monitored them for 2 weeks. This is the control group on the left. We give the GFP virus controlled by a CFOS promoter. The animals continue having seizures, but if we use the CFOS potassium channel virus, then all of the animals have a profound reduction in seizure frequency, and some of them become seizure-free. And we also, of course, had to do the behavioral studies to make sure there were no off-target effects. Now, people then ask, of course, well, if the seizures go away, why doesn't the CFOS promoter switch itself off? Well, these animals do, however, continue having intraictal discharges. And so we think the intraictal discharges are sufficient to keep the potassium channel expression at a level where full-blown seizures are prevented. We've also validated this in human cerebral assembloids. So this was using these mini brains in a dish, and we showed that we can also protect these human cerebral assembloids from a chemoconvulsant insult. Giving first chemoconvulsant insult to switch it on, and then giving another one later. And these assembloids were relatively protected from the second insult. And this was published, as I say, about a year and a half ago. All right, so to conclude, I've described a number of gene therapy strategies for focal refractory epilepsy. The first one is a constitutive approach, just overexpressing potassium channel. It's highly effective. We've reported this in a number of different models. It's a very simple strategy. The second approach is a controllable chemogenetic strategy using a receptor which we can then adjust the effect of the receptor by giving a ligand and thereby adjusting the therapeutic effect. And the third approach is what we call closed loop, either using a glutamate-gated chloride channel or using this activity-dependent promoter to express a transgene, which are two different ways of thinking about closed-loop gene therapy. And I have to say that, what I haven't talked about in depth is a lot of mechanistic insights, which we and a number of other laboratories have reported over the years, looking at calcium, glutamate, and GABA imaging, as well as electrophysiological tools in rodent models of focal epilepsy. And this has provided a lot of insights into the mechanisms of escape from inhibitory restraint, which have led to some of these ideas about what would be the best approach for gene therapy. Now, and finally, I should point out that clinical trials of cell and gene therapy for focal refractory epilepsy are already underway. So Neurona has done some transplant of progenitors of inhibitory cells, and Unicure have just initiated a trial of a gene therapy using kainate receptor RNA interference, so trying to knock down the expression of a subtype of glutamate receptors. And we hope to join them very shortly in a clinical trial of our approaches through this company, which I mentioned. So thank you very much for your attention. And of course, I'd be delighted to answer questions.
Well, thank you so much. This was amazing. I have to admit that at the beginning I was sort of afraid that it might be, too scientific or too, I don't want to say the word basic because there's nothing basic about it. But it was phenomenal. I mean, it was really easy to understand and very applicable. I mean, I have to say that there was a lot of clinic actually in it. And I was amazed that, everything that you're doing, especially the chemogenetics that you talked about, and, activating the receptors from the inside. However, I'm a clinician, I'm a child neurologist, so I'm as far away from the basic science as one can get. But something that I was really thinking about, and maybe you can help me, maybe, it's I don't want to say a stupid question, but so what we see in neonates, and you were saying how you were using, newborn mice, even the in utero mice, right? So what we're seeing in neonates is that GABA is actually excitatory early in brain development. Now, how do you target? I mean, does that create a problem for you when you do your studies?
Yeah, thank you. So that's actually a really interesting question. So as you point out, GABA can be excitatory, and it's thought that this is because in immature neurons, the chloride reversal potential is relatively depolarized. So normally, the membrane potential at which chloride neither goes in nor goes out when you open a chloride channel, such as a GABA receptor, is quite negative, which means that if you open the chloride conductance, i.e. you open a GABA A receptor, the membrane potential will go down as opposed to going towards a threshold for initiating an action potential.
Exactly.
And there is a lot of evidence that in disease conditions, not just epilepsy, but certain other disorders, that there's a failure of the mechanisms that maintain a low intracellular chloride concentration. And therefore, when you open a chloride conductance, instead of chloride going in and making the membrane more negative, chloride comes out and makes the membrane potential more positive, and then can promote activity. And so that made us think, well, would this approach that we used using a glutamate-gated chloride channel, should it work? If the chloride potential, as you allude, if the chloride reversal potential is relatively positive, then perhaps that approach of using a glutamate-gated chloride channel should fail, and if anything, should make things worse. Now, first thing is we didn't see that. We actually saw an improvement in seizures. However, there is another approach to inhibiting neurons using chemogenetics, which is using ligand-gated ion channels, these chimeric, so fusing a nicotinic extracellular receptor to a chloride channel. And people have used this approach as a sort of chemogenetic tool to inhibit neurons. And so it's not using a G protein coupled receptor like a muscarinic one. It's using a ligand-gated ion channel. And there is a paper recently that showed that you can actually suppress seizures using that approach. At the same time, there is also some published data to show that if you use this sort of chemogenetic approach using an ion channel, you can have paradoxical effects. Sometimes you actually make things worse. So we don't know. I mean, the first thing to point out is that when you open a chloride channel, you don't only shift the membrane potential negative or positive, you're also opening a conductance. And so if you've got an excitatory input to a neuron, it can actually act as a shunt. It basically reduces the resistance of the neuron. And so even if the membrane potential is not going down to a negative potential, you can still inhibit the cell, prevent it from firing, just because you're opening this sort of, you're dropping the resistance of the membrane. So there's a lot of unknowns here, but then the question, of course, is, well, can we extrapolate from these mouse models to other situations? Would our technology work in very, very early life? Of course, we can't be certain. Focal cortical dysplasia is, of course, a very, very common cause of epilepsy in children. It's the commonest pathology identified at surgery in children undergoing epilepsy surgery, whereas in adults, the commonest pathology is hippocampal sclerosis. But you know, we think that, well, because it worked in our model of FCD, it may work in children who have FCD. So we think that's very, very important to verify that it does work.
And now that you're on the subject of FCDs, and you know, I'm really happy that you mentioned it. How, you know, the fact is that we have these in your clinical trial, you know, somatic mutations with mTOR hyperactivation, etc. So the idea of the clinical trial that you have is just, you know, absolutely fantastic. And of course, as a child neurologist, you know, avoiding the surgical approach, even though it is very successful, especially for FCDs, would be fantastic, right? Especially if, you know, it would cause some, you know, defects of various kinds depending on the location. Now, what I wanted, maybe I missed it, okay? But maybe you can just explain it to me. Now, would this approach require a prior biopsy, or would you just target immediately? I mean, what would, you know, create the best possible result and you know, target the best?
Yeah, I mean, so that in a way, that's a. I mean, thanks for raising that question, because of course, you know what, you know, ideally you would have some sort of known molecular lesion, and then you go in there and you fix it.
Yeah.
You know, and that, of course, is the basis of the vast majority of gene therapy efforts, especially in pediatrics, you know, in children. Yeah. It's children born with monogenic disorders. And then you're talking about gene replacement for recessive loss of function mutations, or, you know, sometimes you try to repair things by overexpressing some compensatory gene, or if you've got a gain of function mutation, you try to undo it by suppressing the function of that particular gene. In the case of epilepsy, that's not really practical for the vast majority of focal epilepsy. You don't want to have to go in there and biopsy the brain. So which is why we think we're going to take one step back and just adjust the excitation inhibition balance and try to stop the seizure mechanisms or stop the seizure escape using what we know about seizures. Of course, there are some, you know, there are some very important advances in gene therapy and RNA therapy for monogenic disorders, but they tend to be primary generalized epilepsies. But things like Dravet syndrome, there's a lot of effort in Dravet syndrome to mitigate or somehow compensate for the loss of function mutations in sodium channels, either using RNA therapy, like Stoke Therapeutics, or using gene therapy. I mean, of course, there are some special challenges there. That the sodium channel is quite big, so you can't fit it into an AAV. So trying to get that whole AAV sodium channel has problems. So people have done different things, like trying to put in two halves of the sodium channel and then glue it together in the neurons, and various other strategies. We actually did publish, together with Gabriele Lignani, we did actually publish a study where we used this CRISPR activation to try to turn up the sodium channel expression in a model of Dravet syndrome, try to turn up the endogenous wild type copy, because of course the mouse model, in common with the children, has one wild type copy and one loss of function mutant copy. So if you turn up transcription from both, the hope is that you can try to restore a normal complement of sodium channel. But these are very, very rare disorders, and the vast majority of cases of focal epilepsy, you don't really know why the patients have seizures. You can find the seizure focus using MRI and EEG and so on,
Yes.
but you don't really know at a molecular level why they're having seizures.
And we have a question from the audience. First, they're thanking you for a very nice talk. And the question is gene therapy applicable for acquired drug-resistant epilepsies in which surgical intervention is not possible, for example, in case of gliosis?
Yeah, so this is a very important question. So in a way, the way we think about gene therapy for focal refractory epilepsy is that we could try to replace surgery, but also extend to people who are not candidates for surgery. So that clinical trial design I described, where we have patients who have already been approved in principle for surgery, that's where we're effectively replacing surgery. So these are people who could have surgery, and then we would do the gene therapy and avoid the need for surgical resection or tissue destruction using LIT. Then there are people in whom surgery represents too great a risk. And of course, it's not an all or none situation. It's not that people have an epileptogenic focus in completely silent brain area and other people have epileptogenic focus in eloquent cortex. There's a gradation. But you can imagine, when you're counseling people with pharmacoresistant focal epilepsy about the pros and cons of surgery, you have to say there is a certain risk and there is a certain chance of becoming seizure-free. And we know that if a patient has temporal lobe epilepsy with hippocampal sclerosis, there's quite a high chance of seizure freedom. If the focus is in the frontal lobe, it's not such a good prospect. And then, of course, as you go across that spectrum, then there are people in whom the seizure focus overlaps extensively with, Broca's area or motor strip or occipital cortex and so on. And so that's where we think that these different strategies have their advantages. That's why they're not all targeting the same populations. That, if you like, the constitutive gene therapy, we would feel more confident in using that in people who have epileptogenic focus outside or well away from critical brain areas. And for people who have an overlap with the critical brain area, we would feel more comfortable using a controllable gene therapy or using the closed loop approach. Although the closed loop approach, it's still at an earlier stage. We still need to do a lot of fine tuning and validating and humanized models effectively. But the controllable chemogenetic approach is what I think would be more suitable if the seizure focus is more likely to overlap with critical brain areas. And of course, there are other variables. In some cases, you can identify the seizure focus on MRI, and it's very, very discrete, like in some cases of FCD. In some cases, it's more extensive. You have other disorders where it's very, very difficult to model in mice. For instance, subependymal heterotopia or polymicrogyria. These are difficult to model in mice.
I have to say that I keep catching myself smiling as you talk, because it just opens up so many prospects for all of our patients. I mean, it's fabulous. I really have to thank you and your crew and everybody else that's doing this, because somehow, of course, we are used to the anti-seizure medications, and then we get used to having all of these surgical approaches, and now that we're hearing and learning about all of the new prospects, and when you said, I mean, first of all, I was excited when you were talking about this whole, clinical trial idea and how it could actually work. And then now when you mentioned the controllable chemogenetics, and I'm like, wow, just absolutely mind blowing. And I wish I was younger so that I can, actually, apply it to my patients. And I really thank you so much for fabulous webinar. And thank you and everybody who's doing this for doing such a great job. And I'm really blown away with all of your results and looking forward to hearing more. So thank you, thank you, thank you.
Thank you.
Nicole,
Yes, I mean, I have to echo the thanks. I mean, what a lecture. I mean, I must admit, it's going to be one again that I have to go back and listen to again. There's a lot of information there, but I think it will be really useful, and I hope a lot of people do revisit this one. I think it will be used a lot. So thank you very, very much, Professor. That was absolutely wonderful. So I have the great job, of course, of thanking our wonderful speaker, Professor Dimitri Kullmann, and Professor Massimo Leniso, our wonderful chair as always. And also just to encourage you once again, just to complete our survey when it pops up at the end. As I say, this really does help us. It does guide us. We do look at the responses. So please, please do. And keep an eye on our website for the future ones. We have 2 more that will be presented by Epicare in this series, but you can also find out more about the series online. And we, of course, will promote this on social media and in our newsletter as well, so that you can catch all of this series with our other ERNs. We look forward to seeing you in a couple of weeks' time when we have another webinar. And please, everybody, have a great day, great evening, wherever you are in the world. Take care and thank you very much.
Thank you. Bye. Bye.